Does that work? Perfect. So nice to see everybody. We're recording this session for those who can't attend, but thanks everybody for taking the time to meet today. We're going to start off by sort of explaining this new or this semi-new trach mask trial weaning protocol to give people an understanding of why we're doing this, what it looks like, and how we're going to know if it's working or not. And so it's supposed to be informal. If people have questions, they can unmute or just pop questions in the chat, and we'll try and take a note. And yeah, we'll get going. So for those of you who don't know, this is a picture of the lungs. We're starting off this talk fairly easy, and then we'll just get harder from there. All right. So the overview of the talk, I kind of went through it, but the first question is who cares? Why are we talking about this? What some of the benefits to this protocol that we hope to realize are, why we're doing it. Dr. Bosman will go over sort of in-depth the trach mask trial protocol and the evidence for that. Ian and Tim will go over some of the power chart operationability, and then I'll just briefly touch on how we're going to know if this is working or not, and then what I anticipate some of the barriers will be and how we can address those. So the first question is, why are we doing this? We're making a journey. We already know how to wean people from trachs. Why are we talking about taking a trip? And then more importantly, why are we talking about burning the boats that got us there? And I think this sort of speaks to the point of all of this. If we already have been weaning people from trach mask for years, what's the urgency and what's the purpose of doing something? And I think there's sort of a few reasons. One is I think we've got a lot of people that are like the hare that are going to be able to wean quickly, probably could wean immediately, and we want to make sure that we're affording those people the fastest wean possible. Whereas some other people are like the tortoise, where they're going to take a little bit longer. They need to go in a much more slow and methodical way. And if we continuously push them, then we're going to risk failure, tiring out, and slowing us down in general. So we want to make sure that we're not going too slow for the fast people and vice versa. The other thing is something that I anticipate many of us feel, sort of this new week, new mindset idea that we try something and we set into place a plan. And then on Monday morning, when the consultants change, everything is upended and we start from scratch. This is frustrating, I would imagine, for many of our RT colleagues. But beyond being frustrating, it's also extremely inefficient and probably slows us down, because we really, we think, and I'll try and explain how it's true, that if we do something that's consistent, it's probably better than doing 50 different strategies that are all maybe effective, but not applied across a longitudinal weaning strategy. So those are some of the early rationales. The questions then become, is there a point to having a protocol? We all know, and many of us think, that we're able to look at the patient, make the decision. We do 2.5 hours and then 2 hours, 45 minutes, and sort of all these, unique things with our usual care expertise. And that was one of the questions that this group of people, Karen Burns is one of the graduates of our program, tried to answer in a Cochrane review from a few years ago. So what they looked at was whether a protocol compared to usual care, which is what we do in our ICU, whether there's a difference in a variety of outcomes, but primarily the duration of mechanical ventilation. And they found, this is a forest plot showing all the protocols and then the total duration of mechanical ventilation. And the exciting part of this is at the bottom, you can see that in general, protocols are favored. They reduce the time of mechanical ventilation compared to usual care. And what was interesting was that they just found that any protocol, doesn't matter what, reduces the mean duration of invasive ventilation by 26% and the mean ICU length of stay by 11%. Those are massive numbers. These studies are obviously difficult to do because weaning is so complex, but these are very impressive outcomes to see. So then the question becomes what protocol to go for. And I guess another thing that sort of informed us, and Dr. Baza will highlight, comes from a study that was published in JAMA a few years ago. This is looking at 2 different ways of weaning folks. Now, the background of this trial is they had folks in the United States after 21 days go to long-term acute care hospitals. They're all trach, they're all continuously ventilated for 24 hours. And this trial looked at using a screening process where they let them breathe for as long as they could for 24 hours a day for 5 days. And then those who still required ventilators after that were randomized to either progressive trach mask trials or reductions in pressure support in an organized way. A few interesting points that came out of this. This is their flow sheet. A lot of numbers on here I don't think anybody should care about, But if you look at what they had 2,300 patients assessed. They had 500 patients enrolled. And out of 500 patients, if you put them on 5 days of just breathing for as long as they could, and then putting them back when they needed it, 160 passed the screening test, which means that of these patients, 32% were able to be immediately weaned off of life support and didn't require the sort of sequential 2 hours twice a day, 2 hours 3 times a day that we're used to. So it did suggest that a lot of people, or enough people, can be weaned immediately, that it's worth considering. Their screening I mentioned was 5 days of unassisted breathing. They had a trach collar group, which was they just took them off for up to 12 hours and then rested them on pressure control overnight. And then the other group was a pressure support weaning, assessed them 3 times per day, pressure support titrated to a respiratory rate of less than 30, starting at 14 and weaning by 2 centimeters of water every 6 hours. And then once they got on a pressure support of less than 6 for 12 hours, then they went into that 5 days of unassisted breathing. And I mentioned here that 160 out of 500 patients were able to be liberated immediately from the ventilator, which was an interesting finding. They didn't even really make it into the study, but it was probably one of the most important findings. In terms of the results, I said 32% wean immediately. When you look at using trach collars, which I've just said trach masks here because that's our nomenclature, the mean duration of ventilation was 15 days versus the pressure support group, which was 19 days. And then trach mask, 53% were weaned and 10% died, whereas in the pressure support, less people were weaned, more people died. So this was a pretty interesting and I think informative study. So with that, I'll pass it off to Dr. Bosma to explain some more thoughts about our local protocol.
Thanks, Paul. Tim, can you just give me a thumbs up if you can hear me okay? Perfect. So as Paul said, the study that he just showed by Dr. Mal Gibran and Dr. Martin Tobin was really a launching point for this, protocol. But the protocol is a lot of what we do anyway. We're just trying to add in, as Dr. Cameron mentioned, a systematic approach to it, and also add in some nuances where the evidence kind of leads us in one way or another. So the first thing to note is that we want to use this trach weaning protocol in any patient across the unit. So MSICU in our critical illness recovery program or CIRP, or in the CSRU who has a trach. So that's the point for the first point. And because we allow for them to go as long as possible on the first day, it can be for people that are not going to prove difficult to wean or people that may be difficult to wean. That's teaching point number 1. Second thing that I want to get into is I like to use the analogy of training to run a marathon. So going from a complete couch potato to training to run an entire marathon, people do this. And it's possible, and I always give this analogy to patients and their families. But there's a few things to consider when you're about to train to run a marathon. So the first is it safe to start exercising? So for these patients, just breathing on trach mask is a huge workout. And so, for example, if you were on a couch and you wanted to know, can I go for a run? You need to first know, am I going to get angina when I get off the couch? And is my exercise-induced asthma under good control? So just some safety parameters. So we built that into our weaning protocol as well. And next slide. The next question is, how are we going to get from 0 to 42 kilometers of full marathon? Or how are we going to get this patient who can barely breathe for a minute off the ventilator to 24 hours off the ventilator? And so there's a number of things we think about. We need to have a daily schedule and a weekly plan, just like you were planning to run a marathon. You have to give yourself, my goal is to run a marathon in 6 months. I need to start building up to that 6 months now. We need to work out. You need to have times that you run, walk, and rest. And a lot of guides to running a marathon will suggest just that. You don't have to just run until you can't run anymore and then go home. You run 5 minutes, walk for 1 minute, run 5 minutes, walk for 1 minute. And those rests in between are really important. And then the next thing, of course, is that when you're training to run a marathon, sleep is super important. You have to get adequate sleep and muscle rest to repair the muscles and build them up so that you're ready for the next day. And then of course, nutrition is really important. So keeping in mind that same kind of analogy of how do I train to run a marathon, we tweaked the weaning protocol based on the study by Dr. Tobin and adding in some extra steps. So first we established clinical stability for weaning, and that will be your daily screen every day. And then we'll go into tracheostomy mask trials and gradually building up the time on trach mask, and then eventually to an overnight wean. So first thing is safety. So we assumed that every day patients are going to be screened for trach mask. And you only do not proceed with a weaning attempt if they have evidence of respiratory instability, unstable hemodynamics, cardiac ischemia, they're dangerously agitated, or there's something else going on. There's an emergency that merits them to be on controlled mechanical ventilation. But if they don't have any of these criteria, then you're going to go forward with your assessment for weaning. We also want to not push patients to exhaustion or to having a myocardial infarction or anything that would be unsafe. And so we, of course, as you always do, are looking at the patients to see if there's evidence of intolerance or failure. And so two of any of the following criteria, so their SATs are dropping, their rest rate's greater than 35 for more than 5 minutes, heart rate is increased to greater than 140, or it's a sustained increase of 20% from baseline, they're hyper or hypotensive, or their systolic blood pressure has changed more than 30% from baseline. If they have anxiety or dyspnea, if you notice worsening accessory muscle use or diaphoresis, or their CO2 is rising as evidenced by they becoming unconscious. So any two of those are indications that they're failing the attempt and you stop. So first you're going to assess, are they safe to start a weaning attempt, safe to exercise, and you're going to stop as soon as they show intolerance. And then we have the 3 steps of the weaning protocol. So step 1 is your baseline assessment of their initial trach mask tolerance. Step 2 is you're establishing their daily workout schedule. And then step 3 is the overnight assessment and transitioning to either off vent completely or non-invasive ventilation. So for step 1 is the baseline assessment. And again, using our analogy of running a marathon. So our couch potatoes are lined up there at the start line. And the first is just see how far they can go. So not necessarily expecting a huge length the first day, but letting them go as far as they can. So the screening test, you're all aware of because we do it in all our intubated patients, is using the rapid shallow breathing index. And so on the PEEP that they're currently set on, you take away all pressure support or pressure control and let them just breathe unassisted, but on PEEP and the same FiO2 for 2 minutes. And at the end of those 2 minutes, if their frequency tidal volume ratio is less than 105 and their PEEP is 8 or less, they're ready to try a trach mask trial and you can go forward. If they don't tolerate, if they are PEEP greater than 8, but a frequency tidal volume ratio is less than 105, then rather than taking away all the PEEP that they're on, say they're on PEEP of 12, then you might not want to just go to PEEP of 0, but you can do a CPAP trial. So you've taken away their positive pressure support for inspiration, but they're still getting a workout, but you're supporting their oxygenation. And then if they fail their RSBI, their RSBI is greater than 105, then the question is, can I at least try a pressure support trial? And once you establish if you're going trach mask, CPAP trial, or pressure support trial, the next step is just to see how long they can go without developing intolerance. So what that looks like in the protocol is this on step 1. So step 1, the patient meets trach mask trial criteria. There's no safety concerns. If yes, you're going to do your daily trach mask trial screen using your RSBI. And if they, so you do your RSBI at their current PEEP level, but with no positive support for inspiration for 2 minutes. And as I mentioned, if they fail that, they go on to pressure support trial. And if they pass that, you examine whether the PEEP was greater than or equal to 8, and decide if you're going to keep them on CPAP or go on to trach mask trial. If they fail their 2-minute screen test, there's no point in putting them on trach masks. We know they're going to fail, but we want you to try them on pressure support or PAV, and maintaining their P01 in the range of 1 to 3.5 with the resp rate less than 35. And I'm going to talk more about P01 later on. If they did not meet trach mask trial criteria at the beginning, then we're going to, even though they have a trach in place, you're going to continue to support them and reassess daily. So then we move on to step 2. So if they made it to their initial trach mask trial attempt or CPAP trial attempt, you're going to want them usually positioned well, upright in bed. We tried to do our initial trach mask trial when they're in bed and not up in the chair or haven't done any exertion. So timing it sort of before they've had their workout with physiotherapy. And you're going to see how long they can go before they develop intolerance. So if they can go more than 15 minutes, then you're going to let them go until they develop early signs of failure on their first day. So we don't limit the trach mask trial duration. We don't say, okay, this patient just had a trach, we're only allowing them to do 1 hour today. We say, let's see how long they can go before they develop intolerance. And like Dr. Cameron said, in the study by Martin Tobin, a significant proportion of patients actually went straight off the vent and never went back on, and it lasted more than 5 days. And some of our patients that only need an airway can do that, and we've seen that. But if they tolerate more than 15 minutes and less than 6 hours, then we have a starting point of what they can do at their baseline. And then we're going to build on that every day. So if in the first day they did less than an hour, then we're going to say, okay, now we know for tomorrow, we're going to aim for 1.25 hours. If they did greater than an hour on their first trach mask, then the next day we're going to aim for 1.5 hours. And if they did 3 to 6 hours on their first day, then the next day we're going to aim to increase it by 1 hour. Every day you're going to try to increase it in those increments depending on where they were at the previous day. If the previous day they didn't meet their goal of what the duration you had set, then you're just aiming to meet the same duration that you were targeting the previous day. As mentioned, we'd like for the patient to be upright in bed unless contraindicated for most patients, because most of these patients we're assuming have some degree of diaphragmatic weakness. And we're aiming for you as the RT to take control and have a conversation with the nurse at the bedside and the physiotherapist to sort of plan the day in advance. So if you're aiming to come by around 10 a.m. to do your trach mask trial, maybe the nurse can be finished the morning care and bathing of the patient by then, but before the physiotherapist has come in and gotten the patient up, for example. So that's just meant to be a conversation between you and your colleagues to plan your day. What's the best time to start the trach mask trial? We also ask that when the patient that initially the trach mask trials are done twice a day. So once at around 10 a.m. or sometime in the morning that you've set, and again at around 4 p.m. Again, that time can be determined by conversation. Once they're past the 6 hour mark, then we're going to be doing just one trach mask trial a day, but aiming to increase by 2 hours from the previous day. There's always the option of doing a second short trach mask trial in the evening, even when you're on that long stretch of trach mask trial starting in the morning. Really important for these patients is that they're rested at night. And I'm going to talk more about that. And we're aiming to increase the trach mask trial duration in increments until we get up to 16 hours a day. And at that point, we move to step 3. Now, we know that those patients are not all going to just accelerate through this pathway. And so if patients are not tolerating trach mask trial increments, or if they're not even tolerating trach mask trials for more than 15 minutes, then that leads to a group discussion with a multidisciplinary team to look at what are all the factors and address them. So does this patient need kind of halt weaning while we work on their nutrition? Or does this patient need to halt further attempts at weaning until we get them on dialysis and get fluid off? Or has this patient had a new pneumonia that needs treatment? So there might be reasons why we halt the process and then try to optimize all the factors and then restart. So we talked about this analogy again to training for a marathon, where when you're training for a marathon, you run, you walk in between your run, and then you rest. So the run I equate to your trach mask trial or CPAP trial, where the patient has no inspiratory support and all the work of breathing is done by the patient, but their oxygen is supported by oxygen flow, and their hypoxemia may be supported with PEEP. The walk I equate to being on a spontaneous mode of breathing, such as pressure support or PAP, where the patient is doing some inspiratory work, but that work of breathing is supported by the ventilator and shared by the ventilator. It's really important that when we think the patient is walking on pressure support, that they're not actually experiencing like that they feel like they're sprinting and running. So we need to make sure that their work of breathing is not excessive, but we also need to make sure that when we think the patient is walking, that they're not just passive, completely passive on the ventilator and only triggering the ventilator and then being the diaphragm being still. So the question is, how do we determine what is an acceptable work of breathing, not too much and not too low? So work of breathing can be determined by placing an esophageal balloon. And in this chart, you can see that what you'll see on the Hamilton G5 ventilators, your flow pressure and airway pressure and esophageal pressure. So as you know, the esophageal pressure represents the negative excursion or the drop in pressure in the thorax when the diaphragm contracts and the rib cage expands. And that negative pressure can be measured on a graph by taking the area under the curve. So you can see that green area there is the area made by the esophageal pressure dropping and by the chest wall elastance. And if you take that area under the curve, that's measured in centimeters of water, and the bottom x-axis is in time, so it's centimeters water per second. If you multiply that by, so that's the pressure time product per breath. And if you multiply that by the number of breaths per minute, then you get something called the pressure time product per minute. And we know there's normal values for that. So a patient at rest, a healthy patient should have a pressure time product in the range of 60 to 150 centimeters of water per second per minute. Now, we're certainly not asking for you to put esophageal balloons in all of these patients. So there's easier ways that we can measure their work of breathing without esophageal balloons. So if we don't want to take the time to calculate the pressure time product, often what we look at for patients, again, with an esophageal balloon is what is that delta? Like how far, what's the maximum negative pressure the patient generates? And that's a sign of their strength, but the maximum pressure just during quiet breathing. So that delta of the esophageal pressure, a normal range would be 5 to 10 centimeters water. If the patient's on PAV, you know that we, instead of talking about esophageal pressure, we talk about the pressure generated by the respiratory muscles or the PMUS. And we aim for that to be in the range of 5 to 10 centimeters of water. So we do this in the promising study, and all the RTs are familiar with that, how on PAV we can keep the work of breathing in this sort of normal or ideal range. On pressure support, though, you know that we have no direct knowledge of the work of breathing. So if they don't have an esophageal balloon in and they're not on PAV, we don't really know what the work of breathing is. So we need a surrogate for that. And that's where P01 comes in. So our ventilators can give us a measurement of P01 as long as the patient is using pressure triggering. And so what the P01 is instead of looking at the excursion of the esophageal pressure, it's looking at that dip in the airway pressure. And you all know from your experience with patients that a patient that has a very high drive to breathe is taking a big sucking effort just in triggering the ventilator. And a patient with a very low drive to breathe, you might barely see a dip in the airway pressure when they trigger. So what the P01 is it is a measurement of how much that airway pressure drops in the first 0.1 seconds or 100 milliseconds. So in that first 100 milliseconds, the ventilator is just calculating that delta P, but not delta P ESO, the delta P of the airway pressure, or P airway. And so the P01 is that drop in airway pressure in the first 100 milliseconds. In healthy subjects, so right now, us breathing at rest, our P01 should be in the range of 0.5 to 1.5 centimeters of water. So we're not making a lot of huge efforts, and the total drop in our esophageal pressure is probably only in the range of 5 centimeters of water. We know that patients with COPD often have a P01 in the 0.5 to 4 range. Patients with ARDS on a ventilator often have a P01 in the 3 to 6 range because they'll have a very high drive. They often require sedation to knock out that drive. And we know that patients weaning from the ventilator may have a P01 anywhere from 1 to 13 centimeters of water. Dr. Laurent Bouchard and Dr. Irene Telias did a study where they looked at how much P01 is too much. And so they actually had esophageal balloons in patients and looked at which patients fatigued and measured their P01. And what they found was that using a cutoff of 3.5 for this P01, anything above that indicated excessive respiratory effort such that that patient would tire quickly. And again, keeping in mind that while they're on pressure support, we want them just in that walk phase, kind of catching their breath and not overdoing it. So that's why we have in our protocol aim for a P01 of keeping that under 3.5. The other thing that we know from a different study is that a P01 of less than 1 is really not enough work. That will indicate a patient that's very passive throughout the rest of inspiration. And we want the patient doing a little bit of work because the reason they're not weaning quickly is because they've had some atrophy of their diaphragm from disuse. So we don't want to continue that. We don't want to keep them on the couch watching TV, not doing anything. We want them at least up and walking. So when patients, so there's two places where we ask you to just walk the patient. One is if the patient is not even ready for the first trach mask because their RSBI in the first 2 minutes is over 105. That's when we say, let's see how they do then on pressure support, if they can maintain their rest rate, their true rest rate less than 35, and can they maintain their P01 in that range of 1 to 3.5. To do that, you might need to go up to a pressure support of 20, which is okay, as long as the patient looks comfortable, doesn't have that intolerance criteria, and they can keep their P01 in that range. The other time that we ask you to try them on pressure support is if they're really not ready for trach mask. They kind of did 2 minutes, but they can't do more than 15 minutes. Then we say, well, let's kind of see if we can give them a bit of exercise, that walk, and if they can build up to at least 15 minutes. And that's the other time we asked for the pressure support. In our patients in the promising study, they're on PAV. being on PAV with a PMUS of 5 to 10 centimeters water is also that walking, getting them ready to pass their SBT. Okay, so go ahead and go to the next slide, Paul. Thank you. So getting back then to the study that Dr. Cameron mentioned at the beginning, there's a few key points that we took from this study. So the first one that we talked about is that some patients don't need weaning at all. Their first trach mask trial, they fly off the vent. The second point, as Dr. Cameron mentioned, is that the actual reduction of pressure support, a gradual reduction, just slows down the whole process. The patients that came off faster were the ones that just did trach mask, and in Dr. Tobin's study, they rested on assist control ventilation, on pressure control. So that study showed that sometimes I think RTs and physicians have the opinion that if they're not, patients not on pressure support, they're not weaning. But in fact, having these workouts on trach mask and then resting on assist control, this study showed they actually got off the vent 4 days faster using that approach. And had a higher percentage of patients that were able to wean completely from the ventilator. So the last thing that I want to touch on, and it's a big topic, and many of you know, dear to my heart, is the importance of sleep. So again, thinking about our analogy of training to run a marathon and elite athletes, sleep is really important in elite athletes, and it's a two-way cycle. So exercise during the day will improve your sleep quality, and then during sleep the muscles can recover, and then you have a better training effect the next day on your exercise. But if you have too much exercise, if you've overdone it, overexerted yourself, that can reduce the sleep quality and make recovery harder and make exercise harder the next day. And then you get in a vicious cycle. So sleep is important to allow for exercise tolerance, and not excessive exercise. The right amount of exercise is important for sleep. So what do we know about the relationship between sleep and respiratory muscle performance? So there's a couple interesting studies I just wanted to mention. So the first was a study, an old study, just 15 volunteers who they kept awake all night, and then the next day they measured their maximum voluntary ventilation and put them through PFTs and exercise testing, and they found that they had reduced maximum voluntary ventilation. So that's when you say take a as deeper breath as fast as possible for as long as possible. So patients couldn't keep up with that work of breathing for very long. And they had a decreased response to hypercapnia. So when our CO2 rises, that's a very strong drive for us to breathe. And patients that had been sleep deprived the night before didn't have that same response to hypercapnia. And they had a decrease in their forced vital capacity. And so that's probably not very significant for patients who are healthy, but certainly for patients who are already suffering from respiratory disease and trying to get off a ventilator, that can make a big difference. The second study is another small study from the 1980s where they took volunteers again and deprived them of sleep for at least 30 hours, no sleep. And they found that these subjects had decreased respiratory muscle endurance, again, decreased in their 12-second maximum voluntary ventilation, reduced respiratory muscle strength. But in this study, the FEV1 and FVC were unaltered. So moving that, so some physiologic evidence that how we sleep or sleep deprivation can affect how we breathe and our respiratory muscle function, but also there's some emerging and quite telling evidence that sleep in the ICU is really important for weaning. So this was an observational cohort study of 27 patients who were hypercapnic and placed on non-invasive ventilation. And they did 24-hour polysomnography on these patients on day 1 while they were on NIV. And they found that a lot of patients did have very disturbed sleep. They had atypical sleep and pathological wakefulness. So that means that the EEG looks like sleep, but the patient's awake, or the patient looks awake, but their EEG looks like sleep. So patients that had atypical sleep, pathologic wakefulness, less REM sleep, and very abnormal circadian rhythms of sleep that was associated with NIV failure. So NIV failure was defined as death, endotracheal intubation, or persistent need for NIV by day 6. For patients that had better sleep, those were the patients who were more likely to be off NIV by day 6 without need for intubation. Delirium was found in patients with more abnormal sleep patterns and NIV failure. And the question was it the fact that they weren't breathing well on NIV and likely to fail NIV causing them poor sleep, or was it the fact that they weren't sleeping caused them to fail NIV? And we don't really know. It's probably a two-way street. The next study I wanted to tell you about is another interesting study looking at the impact of sleep alterations on weaning, this time of invasively ventilated patients. So the first study was non-invasive, this is invasive ventilation. So again, they did, this was a study again by Laurent Brochard and others. His colleagues in France, not by Laurent Brochard, by Arnold Dill. So they performed polysomnography after the first failed SBT in ICU patients. And they found that, again, a high percentage had atypical sleep. But interestingly, the duration of weaning was longer in patients with atypical sleep versus those with more normal sleep, and in those with no REM sleep. And so atypical sleep seems to be associated with prolonged weaning. And again, probably that by causal effect. So we know that, or this evidence suggests that sleep is important for respiratory muscle function and for weaning. But how do we sort of optimize then the mode and settings of ventilation so that we don't get into this vicious cycle? So there's been a lot of studies looking at mode of ventilation, settings of ventilators, and sleep. And one of these studies I did in our ICU several years ago with your help. And you'll recall me coming to the bedside with this cart with polysomnography to hook up the patient and monitoring for the respiratory status. There's been several studies, and what they've shown is that in patients, if you can advance, Paul, in patients with acute hypercapnic respiratory failure, we know that sleep quality is better on NIV than off. So if you have respiratory failure, you need that support to your ventilation during the night to help you sleep. We also know that in patients who are invasively ventilated, if we completely rest them respiratory muscles at night by going up on the pressure control and backup rate until the patient is just riding the rate and completely passive, those patients have improved sleep quality compared to patients that are working through the night on low pressure support. And then finally, we also know that we can overdo it. So if we have overventilation on pressure support, such that the patient's becoming hypercapnic and blowing off their CO2 too much, that can induce central apneas and a lot of sleep fragmentation. So getting the right amount of support is really important. Finally, we know that excessive asynchrony with the ventilator can also cause arousals and awakenings from sleep. So we want, again, to have the patient well synchronized with the ventilator, but with the right amount of support. So looking at what mode to use or versus how to set the mode, the evidence seems to suggest that more support at night is better, but it's really not so much about the mode as it is about the patient's work of breathing and asynchrony. So again, we want to avoid ineffective efforts and dysynchrony, but we want the patient to at night have that respiratory muscle rest and be really well supported on the ventilator. The next slide shows a number of studies, in a number of different studies, how many arousals and awakenings per hour patients had on different modes. So the first study shows assist control versus pressure support, assist control in the blue. And you can see that arousals and awakenings were lower on assist control than pressure support in the green. The next study shows not a big difference between assist control and pressure support. And the third study shows no difference at all. But you can see there that the number of arousals and awakenings really varied between the studies. And that third study there, where the patient had low number of arousals and awakenings in both assist control and pressure support, they were very well supported. And then, sorry, Paul, just if you go back, in the fourth study and the fifth study, those were studies looking at pressure support and PAV, showing that PAV seemed to be superior to pressure support in one study, but no difference in the other. And again, it depended on what the work of breathing was. So what we decided for our weaning protocol was that we wouldn't be overly prescriptive to the RTs. So we say rest at night, we emphasize that, and you can use ASV or assist control. And most often pressure control is more comfortable, but we're sort of avoiding pressure support unless they're spontaneously going into pressure support mode on ASV. We thought that that was a good approach because you as the RT at the bedside have the best hands-on eyes at the bedside to see if your patient looks comfortable. So we don't want them working overnight. We're not trying to wean overnight. We're trying to rest, but you can decide if they're on ASV or pressure control, how they look the most comfortable, and what their rate is. Just the goal is resting them. And so also resting them, again, well supported in between those trach mask trials. So ventilator settings, we leave fairly open to you, but the key things are that you want to avoid hyperventilation. So if you're seeing your patients having central apneas, that means your rate of ventilation may be too high. Again, alleviate the work of breathing, but avoid excessive support, which may lead to asynchrony. From the literature, it seems that targeting lower tidal volumes may be helpful, as higher tidal volumes lead to that overventilation. So keeping target tidal volumes less than 8 mL per kilo or closer to 6, and allowing the rest rate with those lower tidal volumes to be up to 30 to 35 seems to be acceptable. Often we're sort of saying, so we get a broad range of rest rate 20 to 35. We don't want them higher than 35, but again, keeping in mind the literature shows that it's okay for a patient to ride the rate at night and just be really, really rested. And again, avoiding asynchrony. So I hope that kind of gives you an idea of the evidence that we brought to the table to why we created this the way we did, really resting at night and in between those workouts, allowing those workouts and of trach mask trials and expanding them, the duration as tolerated. And then for those patients that aren't quite there yet, using that walk analogy of pressure support or PAV, but keeping the work of breathing in a reasonable range by looking at the P01 and looking at the patient. Finally, when they get to 16 hours off the day, we look at overnight weaning. And some patients, after discussion with the physician and nurse at the bedside, will be ready to attempt overnight weaning. We know that many of these patients won't pass their overnight wean the first night. And again, it's sort of a jump in and try it rather than an increase gradually. So the first overnight is just, let's see if they can go overnight, but check their gas in the morning or and evening, or use transcutaneous CO2 monitoring with a threshold for putting them back on the vent if you see an increased CO2 and low pH. Not uncommon for patients to pass off vent for day 1, 2, 3, 4, 5 and fail around day 5. So we will watch these patients in the critical illness recovery program for a good week, probably, and when they come off vent, just to make sure they're really well weaned if they've had this long trajectory of weaning. If they are not tolerating off overnight, the two options, the best option is probably to transition them to non-invasive ventilation versus just gradually increasing the duration of their overnight stint. To transition to non-invasive ventilation is a whole other topic, so it's not addressed by this protocol. We'll be developing other protocols for exactly how we go about that. You know, when do we downsize the trach? How do we institute NIV, and relying on our colleagues from HRBC to help us with that. So that's all I have to say about the 3 steps to the weaning protocol. And we've been really fortunate to have Ian and Tim and others working on translating this protocol into actual order sets. And so I'll hand over to Ian to talk about how we order this on PowerChart.
So this went live now earlier this week, last week.
This week.
Anyways, this week, yeah, it's live in PowerChart now. If it's ordered, you can. It has the prefix CIRP, and it's under the trach mask trial protocol. And once it's ordered, it's ordered as it includes all 3 of those steps, and it was made to follow the protocol, and it's got a link to the protocol there. So if you advance one more slide, the yellow bar there, the vent weaning protocol, if you click on the little icon beside it there, there's not a picture over here, but it does include those exact slides that have the different stages listed in a more graphical format that's a little easier to follow. But within each of these steps has the orders that you require for the changes that you need to make there. And so this is step 2 now. And there is a caveat on each of the steps here that says basically when you're done with this particular phase, you can discontinue this phase and activate the next phase. I don't know, Tim, if you want to comment on any of the phases and the orders here.
Just the fact that when you step from phase to the next phase, it doesn't necessarily mean that we can't revert back into the original step. That's still existing, and it's still part of the order. I think it's important to remember because some of our patients do decompensate, get septic, and they may no longer be weaning. We may move back to the first step where we have to reassess.
If you go ahead 2 more slides there. And this is how you would, I was playing with it today just to see how that looks. And what happens in the top image there, it's got the step 1, step 2. I was in step 2, and then we went to step 3. But then let's say they failed step 3 or didn't want to be in step 3, wanted to go back to step 2. So I was able to discontinue the phase that you don't want. In the bottom left picture there, you right click the one that you want and just click discontinue. It allows you to discontinue it. And then what you will need to do is go to like if you wanted to go back to step 2, if you go back to where it says step 2 discontinued, the one that we had already if you right click it and you click replicate, it will allow you to reorder that step again, and it will become your active step, and it will be then bolded as you could initiate it again.
And I'll just add, Ian, that if anyone's interested that's on today, our patient in bed 29, we've ordered this on, so you can kind of see it in PowerChart and see what it looks like. That patient is just on step 1. So we ordered this on Wednesday. Patient failed step 1 RSBI, tried pressure support. Patient was asynchronous and uncomfortable on pressure support, and back to pressure control. And then again, every day at reassessment. So Thursday, Friday, failing RSBI, but now tolerating pressure support with a P01 in range. So you can kind of see how that looks at that bedside.
One thing I talked to clinical informatics today just to see, because the link to the protocol that was in yellow on the previous slide at the top there, they just changed it so that always stays active now. I guess initially when they launched it, it was a one-time thing and then it would disappear. But they said they changed it. So it should always be there now. So if you find that it's not there for any reason, please let us know so that we can make sure that that link is always available.
All right, so I'll just sort of wrap up like some of the points we've already made, but the goals and the outcomes that we're looking for here. I think the main outcome is really to promote, well, one of the main outcomes is to promote consistency. As I mentioned, every day, every week, remaking the entire plan with different RTs, different physicians. We have a lot of variability between individuals, and that just in and of itself creates problems. We know that doing something, some sort of organized plan is good. And so we're trying to promote consistency. Really what we're trying to do is promote faster weaning so we can have a reduction in days of invasive ventilation, which is patient centric as well as nice to do. And then the last thing I think is really for one of the important things for me is this less what are we doing today conversations. I think for anybody who knows me, they know I'm fairly fond of myself and I find myself to be quite intelligent. But, you know, if I'm saying, let's try and do this, you know, very specific plan, and then the next week it's all changed, it really doesn't matter. And so when we ask, what are we supposed to be doing today? Even those of us who have the greatest ideas, we really need to promote consistency among all providers week over week. And so I think that the benefit here is to have more of a default structure so that when we come in, we say, this is what we're sort of defaulting to, this is how we do it here. And then we reduce some of that individual variability. In terms of just two pieces I want to talk about that we're going to try to promote this, the stability of this. One is evaluation. So Kathy Maudsley is tracking some data. We're thinking about how to track this, what data to use, how to present it. But you can see this is over the recent past, people when they were admitted, their trach date, their first trach mask trial, the duration. I'm not going to read every column here, but really that we're trying to gain an understanding of how, is this working? Is it working like we expected to? What are the snags? Where are we getting caught? And another big part of that is informal. So for the bedside staff to talk to the physicians, Dr. Bosma, myself, talk to Tim and understand what parts of this protocol suck and what do we need to amend, because this is not meant to be a once and forever type of situation. It's meant to be living and receptive. And the other thing is culture, which I'll sort of talk about in barriers, but I just created a screenshot here. Ron Butler, who is sort of one of the people certainly that we all look up to in our division, sent this to all the physicians you can see here in the list, explaining that this is the protocol for consistency's sake and to promote facility for the protocol. We're hoping that everybody follows it. At least in MSICU for now, whether or not they're a CRP patient. So it's being taken seriously by the consultants to try and use this and go forward from there. I'll just close with some barriers that I can sort of foresee. I sort of talked about this loss of control or creativity. I think all of us, again, think that we're good. I think all of us are good, but the issue is that everybody does it slightly different, and we run into difficulty with 1,000 different approaches to a problem. I think there's a question of whether or not we're fixing something that isn't broken. We've already weaned people. We weaned people for 30 years, which is true, but I do think that some of the emerging evidence suggests we could probably wean people faster and better with more individualized, personalized approach. So I think that there's value to, while it's not broken, we still get people off ventilators. We can probably do better. I think there's some questions of whether it's practical to have this sort of extensive protocol. Realistically, I don't think you'll find it's that different than what we already do. It just adds a layer of sort of, again, defaulting, so it becomes more straightforward. Universality, I think, is tough. I think that there's going to be initially people that say, well, this person didn't do it this day, so it doesn't work. It's not going to be used 100%. We sort of expect that. We know that people, like I said, like myself, fancy ourselves to be better than everybody else or better than the protocol. And that's okay. What we're trying to do is promote the conversation of default. So when you come in the morning, this is what we both understand is going to be done today. And if folks deviate, maybe that's good. We'll learn something from that creativity, but we want to try and change so that maybe 80% of the time we're doing what has been shown to be evidence-based and effective. And then the last thing is, are we going to just do this for fun and not know if it's working? That is a barrier, trying to get data, trying to feed that back, trying to determine how we assess the workability of this. I'd say those are still in progress, but you know, those of us who work back in this area are committed to seeing if it's working and to thinking about how to evaluate it and then to adjust it as we go on. So that pretty much wraps it up. I think I've tried to impress upon folks that I think some sort of protocol is better than nothing. I think that promoting consistency and the use of defaults in terms of all of us agreeing, or at least many of us agreeing, that this is how we're going to generally start trying to do these things, I think is going to have benefits in terms of achieving this consistency. And then I think we already do know how to wean, but the additions or sort of the tweaks I see that are most important, and Dr. Boss went into detail, would be how we do overnight, with trying to achieve rest overnight and then allowing folks to train for their marathon during the day. I think that this will allow us to wean people more quickly, because if I had one gut sense, is that we have folks get trached and then we start off with 1 hour of trach mask in a day, and we're probably missing people that could do 10 right off the bat. And so we're keeping them in the ICU and subjecting them to all the issues with that. And then, starting to use P0.1 and trying to be as intelligent and as targeted with our pressure support as possible is another goal. And ultimately, the goal of this is liberation, is freedom. The goal is to try and help our patients wean off of invasive ventilation as quickly as possible. And we're hopeful that this is a step in that direction. So with that, I will close. I'll keep the recording going in case folks have questions, and be happy to welcome them.
Sorry, I just want to make a comment that just for the RTs that I know that Kathy is taking all that data in. So it's super important to chart our durations of trach masks as we've outlined in the past. And if you have questions about it, let me know, because there's been more than once that I've had to help Kathy track down the numbers. So just super important for charting.
If I can just jump in and add one thing, and that is a big thank you to the RTs. So as many of you know, although we're sort of going live, rolling this out in the power chart version this week, work has been going on with this since the spring, started by Kyle Fiorini. And so thank you to all the RTs that gave Kyle feedback. So this was tweaked and adjusted multiple times. I think this is sort of the third or fourth version of it. And that was related to the RTs saying, yeah, this didn't work, or this didn't make sense to me, or what about this, or there's a loophole here. So keep that feedback coming if you see things that don't make sense or you have questions. But thank you for all your input into what we have so far.
Hey guys, thanks for this presentation. It was awesome. We have a few questions from the RT gang. Mike's, the first one was kind of any consideration where you'd like us to start out with speaking valve with these trials.
Yeah, so we talked about that quite a bit, of where and how to layer that in, and we didn't. So Dr. Lisa's previous trach mask protocol that he had beautiful like step 1 to 7 about when to introduce speaking valve and how to do that. We didn't layer that in. Tim, do you want to talk about how the RTs should approach that? We sort of left it like it's a conversation between the RT and physician, but any comments?
The way it's set up now, the speaking valve, if we feel appropriate or we feel the patient would benefit from it, feel free to use it. It's in the initial step there that if you think they're going to benefit. If for some reason the consultant has said that it's inappropriate to use the speaking valve, there is an issue with the tracheostomy procedure that they think the person would not benefit from it, that's when you wouldn't use it. So it's already written into the orders. I think anybody that's looked at that one patient's order set in the chart, you can see that speaking valve's already been ordered. So unless otherwise told, don't go ahead and use the speaking valve.
Something else that came up today, we did the initial trial on a patient, the lady in bed 29. So she did 2 hours of trach mask trial, and then we rested her. And according to the algorithm, it's at least 2 hours of CMV or ASV. She won't do another trach mask trial today, but are we okay to do pressure support trials for the rest of the day and then rest her tonight?
Short answer is yes. the rest during the day was really meant to prepare them for their next trach mask. And I didn't know that when I went by this morning, and then when I went by after, I didn't realize she had a trach mask trial in between, because I saw her and I just quickly did her RSBI and she failed for me. So it must have been after her first trach mask trial. She did how long did you say, Trina?
She did 2 hours. And actually looking back, we said she technically did fail her rapid shallow breathing index, but we thought she'd only tolerate about 15 minutes and she did really well. She was tachypnic the entire time, but she did 2 hours of trach mask.
Okay. And then she rested, and now you're wondering if she could be on pressure support. I don't have a problem with that. I think the big thing is like to rest her tonight again before tomorrow.
Okay, I'll give that feedback. And then my final question, we have had a patient in CSRU that has been on the weaning protocol, and then a consultant kind of expressed his dislike in it, and we reverted back to kind of what he preferred. And I was just wondering how you would like us to go about that, because it kind of, puts us in a sticky situation, I think.
So that's really good. It's good to know. I would suggest that a conversation then happens between one of the other CSRU consultants. I don't work in CSRU, but Ron and Paul, do you have suggestions on sort of how to approach that with the physician group, or?
I think let Ron and I know. I think that's what I'm getting at, that there will be people that deviate. I guess to Trina, answer your question simply, I think you're going to default to who's there in the moment. I think we don't have a solution to people that are going to go rogue. But I think that, bring it to our attention. It will be something that's addressed. That was my goal of showing that email, that we are willing to sort of take this on and try and encourage people, but it's not going to be probably 100%. I would say, if we're advocating, if we're saying this is the protocol, this is what we've agreed upon, then we're going to have the highest chances of success. But other than bringing it to our attention, we'll try and take that on from a leadership ownership perspective at the physician level.
I think that's it for questions from the gang at UH. Thanks for doing this, guys. It was really informative.
I'll just really quickly just show you the speaking valve order that Tim referred to.
Any other questions? Michelle, I would love for this to be a Vic thing at some point as well, but we'll cross that bridge maybe in a little bit. But if you want to have further chats, please reach out.
I would love for it to be a Vic thing too.
I mean, ultimately, I honestly think you could probably just start ramming it through and just have it start being ordered. And then I really think the power of defaults here is important.
Yeah, and the fact that there's already an order set for it, that they don't have to look for it, they don't have to do anything. Thank you for all your work.
And I think, Michelle, one of the selling features is that I think it actually kind of gives more control to the RTs, because you don't have to necessarily go to the physician each day to say, what are we doing? As Paul was mentioning, that what are we doing today conversation doesn't have to happen, because you already know what your plan, the default plan is, unless the patient can't, goes off course for some other reasons.
Yeah, I'm hoping to get John and Murat on board, since they work at your side as well, and then hopefully they can sing its praises to the physician team here. So.
And we want to hear, Paul and I and Tim want to hear if people don't like particular parts of it, or you don't think it's working. That feedback is just as important as the positive. So we want to hear the good and the bad.
Absolutely.
Michelle, just because
Yes.
you're our RT one chart super user, when the protocol got ordered, we had a ton of respiratory referrals that weren't necessarily pertinent to the patient at the time. How would you go about cleaning those referrals up if we can't? Like, one of them would be speaking valve, a transcutaneous CO2 populated, and they're all in the referrals, but ERTs were reluctant to sign off that if they weren't actually going to do that. So our thoughts, our initial thoughts between Trina and I is maybe we put it into the situational awareness. So, or you know what I mean? So people knew about it just so we could clean up the referrals, but I'm not, what's your thoughts?
If you signed off on it, we could still have it visible in the respiratory order details component of the respiratory therapy workflow. So they
Okay.
would still be able to see it, but it wouldn't be front facing whenever they open up Power Chart for MSICU or CSRU or whatever area. they're
Okay.
working in. I don't know, we could ask Lucy as well if she has any thoughts
Okay.
on it, because it would make for a really busy respiratory referrals page.
And that's what it looked like this morning when we were looking at it. So we'll talk off the meeting, and we'll come up with an idea how to
Okay.
present to the group.
All right, I'll give a last call for questions, either chat or unmuting. Wonderful. Well, then I'll close and thank you everybody for participating. We'll upload this to YouTube without patient stuff. And if people have questions, just drop us a line. So have a great afternoon, a great weekend.